Good morning and welcome to the Davies Use Case webinar being presented by Ochsner Health System on population health. This is a Davies award-winning use case for the value of health IT. My name is Arnold Simmons. I'm the Manager of Quality and Patient Safety Initiatives at HIMSS, and it's my pleasure to moderate this presentation. Core to the HIMSS mission is promoting the use of health information and technology to improve the quality of healthcare delivery. HIMSS promotes and advocates the integration of clinical decision support and best practice guidance, access to clinical data to analyze progress, and IT-enabled patient safety tools for all healthcare organizations, clinicians, patients, and community members as vehicles for improving patient outcomes. The HIMSS Nicholas E. Davies Award of Excellence is the pinnacle of the HIMSS Value Recognition Program. The Davies Award recognizes outstanding achievement of organizations from around the world who have utilized health information and technology to improve patient outcomes and value. The Davies Award-winning use cases have been peer-reviewed to validate sustainable, improved patient and business outcomes resulting from health information and technology-enabled care delivery. So it's my pleasure to welcome our speakers from Ochsner Health. I will turn it over to you gentlemen, and you can begin when you're ready.
Thank you, Arnold. It's a pleasure to speak to you all today about population health and the work we've done here. My co-presenter, Dr. Philip Horvitz, is our Chief Population Health Officer, and I'd also like to recognize Susan Muntz, who's our Director for our ACO Performance Program. We are going to talk about the problem that we have faced over the last decade or so, which has been a progressive switch in our payment models from fee-for-service to value-based models, and this has really been a fundamental shift in how we practice care across our healthcare continuum. The demands from an IT perspective when you're in a value-based model is an order of magnitude greater than in a fee-for-service model. And so it did really require a collaboration between our population health team and our information technology team to be able to solve this problem. We tackled this by going after the governance of the problem first, designing different population health initiatives where we thought we could get the most bang for the buck, and then trying to hardwire it across our system using technology in our EHR solution. We'll also then talk about the quality outcomes that we saw and the financial implications from that.
And as you've heard a little bit about the move to value-based care, I would describe that we here at Ochsner have a significant portfolio of value-based programs. And that ranges from full capitation in a Medicare Advantage product to the Medicare Shared Savings Program, where this year we transitioned to Track 1+, so we're having downside risk there. And then we really have shared savings programs with every commercial payer. We're also the largest private employer in the state of Louisiana, and for which we're self-insured. And we are part of we were mandated into the bundle payment program specifically for joints and have had really good performance there. As part of our Medicare ACO, we have been in an alternative payment model from a macro perspective, and have used really our technology platform to very successfully report our quality metrics for these programs. So you'll be seeing some of that later in the presentation. And this slide, although it's a busy slide, really is just a reminder that everything we do is focused on the triple aim, right? How do we improve the patient, how do we improve the health of populations through measurable quality improvements? How do we reduce cost of care? And more importantly, give patients better experience. And we really add a fourth element on how do we care for our caregivers? Right, where we're addressing provider burnout, as many of you are in your systems as well. So focused on the triple aim for all of our programs. So let's talk a little bit about our framework for population health here at Ochsner. And really, we're going to really address in pretty significant detail today these three elements. right? What is the governance of our population health platform? You're going to hear a lot about our IT functionality and how we use technology to support that work. But more importantly, just having both of those really don't make much sense unless you can operationalize and actually move the needle on your programs. And you see we've built out a nice portfolio of operational workflows that bring this all to life to improve the AAA. So let's first talk about our governing committees. We do have a population health committee. It meets every other week, so we have a pretty rigorous rhythm for how we really bring decisions to the fore, and the decisions really are around which programs, how we're going to prioritize our program development, and more importantly, how we use our technology decisions. There are about 30 members of the Population Health Committee, and it's represented by, you see all those areas on the bottom. We really have wide representation to really understand, the workflows that impacts of really our decisions. And then really where the next level down is our Primary Care Council, which again consists of our system chair of primary care as the lead, all of our regional leadership down to the site lead. And you see a rather large group, but when we come up with a decision at the Pop Health Committee, trust me, the first place it goes is to the Primary Care Council for more widespread feedback on how we are going to implement some of our decisions.
So from a technology design base, we've used a lot of different tools built into our Epic EHR. So we took advantage of the health maintenance functionality in the system to provide bulk ordering, order sets, and we created written order guidelines so that orders could be placed without needing an order for the provider up front. We've leveraged our Healthy Planet registries to try and identify a lot of different populations where we feel we could improve the quality and close care gaps. We then on the back end used reporting workbench, business objects, and dashboards to provide analytic information and reporting information to our executive leadership all the way down to our frontline users. We created health risk assessment visits to try and capture HCC conditions and developed our own calculator to do that type of reporting. In another webinar here, we're going to talk later about our digital medicine program, which has been crucial to the care of several different chronic conditions. We realized we can't do this alone and have been integrating our work across platforms with our social workers as well as with a partner, Care Harmony, to deal with our chronic care management patients. We are committed now in 2018 to adopting social determinants of healthcare as an active component of how we're caring for our patients, and you'll hear more about that at the end of the show. And then finally, we're use the GPRO tool to integrate our reporting back to the MSSP program. Here's an example of what health maintenance actually looks like for our providers. So you can see anything from standard preventative health care, things like immunizations and lipid panels, to more specific disease-related management, such as hemoglobin A1Cs and foot exams in our diabetic patients. The system auto-recognizes from the registry what patients have what conditions and auto-assigns them the correct health maintenance. We also realize that patients are different, and so the providers have the ability to create override modifiers. So, for example, colon cancer screening, if a patient has an adenomatous polyp of the colon and needs to have a colonoscopy done every 3 years instead of every 10 years, a modifier can be added to their system, which then changes the rules for the health maintenance for that patient. We wanted to make this one-stop shopping for our providers. Again, the fourth pillar of the four-point aim is really to try and make things easy for our providers. And so we've done that in health maintenance by creating a health maintenance perfect care overdue smart set. This smart set is auto-suggested if any care gaps exist on the patient, and when the provider opens the smart set, they only see orders for care gaps that are missing for that patient. When they select the appropriate order, the order is auto-associated with the correct billing diagnosis, allowing for one click and done for our providers. As we mentioned, healthcare has really become a team approach, and we're dependent upon all members of the team to provide information for the care of the patient. We've created HRA visits to try and assess care gaps as well as understand some of the social aspects of care that our patients are undergoing that influence their outcomes. We use the care coordination node in EPIC as a way to communicate between the folks doing the HRA visits and our primary care physicians. So the HRA visit providers simply type a smart link, and the overdue health maintenance that's required for that patient auto then populates this care coordination field.
So what brings this all to life is really a broad, focused approach at the team-based primary care level to identify patients at risk, to close care gaps, and engage patients in their own care. One of the keys to this is really, from a population health perspective, is to build registries across chronic disease and preventive disease states. And we've taken full advantage of the Healthy Planet platform that comes in our EPIC system. You'll see here just a variety. We're up over 35 registries built. And indeed, now that our team knows about, or now that our system knows about registries, we're getting requests every day to build more registries. And people are recognizing that although the care of the individual patient is important, the care of populations of patients are now equally important within our system. And how we use the registries, we use them to drive efficiency for outreach to our patients to close care gaps. And this is just an example of where we place bulk orders and really use our portal to do bulk outreach for closing care gaps. You'll see here that our diabetes registry, which is our oldest registry, it's now sitting on about 3.5 years old, and it's functioning very, very nicely. We have over 71,000 patients in the diabetes registry. About half of those are attached to our primary care docs. But on a weekly basis, we find folks who are coming overdue for their health maintenance, such as getting an A1C or a retinal exam or nephropathy monitoring, and then we outreach to the patients. And that has been a very, and it's all done under written order guideline, as you heard, so it's a very efficient process to reach large numbers of patients. And this really is the flywheel that makes it all happen. And if there's one slide I could always point you to, it's really what we call our population health cycle. So we have care coordinators in our practice, in our primary care practices. Our ratios, people always ask me about that. We have about 4 physicians to every 1 care coordinator in the practice, and a care coordinator can manage about 10,000 patients. They do the pre-visit work where they're identifying the care gaps, and under our written order guidelines, either get these tests ordered or tee them up when the patients show up. The goal during a visit is really to close those care gaps. And so, you know, the goal here is to make the provider's time as efficient as possible so that they can practice at top of license and really focus on relationship with our patients and not hunting through our EMR looking for overdue health maintenance topics. So we drive efficiency to make the visit work more productive for our providers. I call that the care of the scene, right? Close care gaps when the patients are in front of us. More importantly, as you heard, the registry work in population health is the care of the unseen, and it's how we use bulk orders and notification. How do we take care of the people who aren't coming to the office today, that you know, the practice may be totally unaware of? And so that's really, you know, care of the seen, care of the unseen. That's the flywheel that improves our scores across the entire book of business. And you heard a little bit about the evolution of primary care here at Ochsner. You know, the traditional encounter-based model that, you know, many of us still live under. You know, the days of a physician and an MA and a receptionist, those days are gone. And you see we now have a variety of care coordinators, diabetes educators, case managers, social workers. We have now built a team around the patient, really led by the physician, to improve the triple aim, you know, for our patients. Focusing back a little bit onto our registry and our Healthy Planet build, all registries have pretty strict documentation requirements. We won't build a registry without a set methodology to document how we built the registry. So this is an example of how we adhered to NCQA criteria to identify our diabetic patients and populations through encounters and pharmacy data, right? So we're using that. So we have this documented because I'm always asked, 3 years into it, who did you put into that registry? So we have a very strict methodology of documentation. We just won't build a registry until we have that to be forevermore encapsulated in our system. And you can imagine, very standard diabetes registry metrics. We're tracking A1Cs and LDLs, blood pressure control, nephrology, eye exam, foot exam, and statins. Right, so very standard metrics that we're tracking for our diabetic patients. And just an example, more detailed, right? We look at patients 18 to 75 who had an A1C in the last 12 months, and we refresh it daily, and then we're giving the provider on a 12-month rolling basis, so they can see their metrics.
And this is what they see when they log into the system. It's right inside the electronic health record. It doesn't require them to go to a separate system. And they see their performance. They see the performance of their peers in their clinic. They see the performance of their whole geographic area, and they see the performance of the system. This is all graphable over time so that they can track how they're trending, if they're having improvements or not. The red scores represent scores that are worse than what they were last year. The yellow scores are not at goal, and green represents they've achieved the goal for the year. So this data is a little bit old. Our dashboards, I'm pleased to report, now have much more yellows than greens. In addition, we take that data and aggregate it in a normative way and an unblinded way and give it to all our providers directly as well on a monthly basis so that they can see how they're doing compared to their peers on a regular basis. This takes full advantage of kind of peer pressure, but physicians in general are fairly competitive and they want to be at the top of their game. So this has been very effective at driving results for us. With this, we've been able to do tremendous things as far as the bulk outreach. So here you can see our diabetic registry outcomes from 2016, and I will tell you the data from 2017 is even more impressive. But across the system, we had over 50,000 care gaps that were closed in labs alone just in 2016. So this is fantastic, and we're really encouraged by the last number on the column of 86%. So the number of patients who we did a bulk outreach to responded to that bulk outreach by completing the task 86% of the time. That's been a tremendous source for us of the ability to leverage that patient portal to achieve these quality outcomes. Here we see the data for 2017, over 20,000 care gaps closed just in some of the more common general preventive health maintenance activities, including mammograms, colon cancer screenings, lipid panels, and microalbumin. And again, a very high response rate among our patients.
Another factor that we use our registry for is really to put patients into diabetes disease management programs. And the nice thing about our registry is that it allows us to immediately stratify our diabetic patients into risk categories. And you'll see here that, we take our diabetics and stratify them into high, moderate, and low risk. Predominantly, we're doing it based on A1C criteria right now, but we're looking to improve that stratification methodology. We're always looking to have better predictive models as to who the rising risk patients are. And you see we have a corresponding set of interventions, right, that correlate to the level of risk. Here's an example of some pilot data for diabetes. So if we send patients to refer patients to diabetes education, again, we're simply showing that based on our education program, that we can have impacts on A1C control rates for our diabetics. I would say, just as an add-on to this slide, we have automated the referral to diabetes education, so that any patient who has 2 consecutive A1Cs that are out of control, we will automate under written order guideline a referral to diabetes education. What we're doing here is trying to overcome the therapeutic inertia by some of our physicians and providers to get their folks under control. Another innovation that we're doing is really offering diabetes education using a telemedicine platform. And we're now bringing patients into remote locations and starting to offer diabetes education in really new alternative formats. We're getting really good feedback about doing this so far, and we're really challenging ourselves to meet the patients where they are.
I think this is going to especially be prominent as the changes to the physician fee schedules are allowing reimbursement through telemedicine. So we look forward to continuing to expand this project. As a system level, we see how we're doing on an overall level through our, we call our Elite 8 ambulatory metric guidelines. And so this dashboard is displayed throughout the system. And actually, our executives all the way up to our CEOs have their bonuses tied to performances on how we're doing both on the ambulatory and the inpatient metrics here. These screens are fully drill downable. So as a provider, I can see how we're doing on the system. I can screen down to myself as a provider, and I can even then screen down to patients missing that individual care gap and be able to contact them directly. This makes this dashboard an actionable form of metric. So what have we seen from the results of this? Really astonishing results. And so here you can see the rates where we were at the start of Q1 16, 17, and 18, and where we are year to date, and really significant improvements in our ability to do difficult tasks such as control hypertension and control diabetes, closing care gaps such as diabetic eye exams. Even colonoscopy and colon cancer screening rates have gone up, cervical cancer rates, mammography rates, and we've added 2 new metrics for 2018, statins for atherosclerotic disease and postpartum care. This is another way of showing that data. This is year-on-year absolute % increase from January 2017 to January of 2018. And again, you see significant improvements. Most notably, I'd like to point out this hypertension control, where we had an over 25% increase in the absolute rate of control for patients with hypertension. We mentioned a little about the HRA visits and their ability to close care gaps, and this is an outcome data that actually proves that. So you can see here for the folks that in green did have an HRA visit versus those that did not have an HRA visit in red, significant improvements in the rates of quality performance across some of these health metrics in closing their care gaps. We also designed a system to try and capture HCC data. We know this is very important in a capitated model to be able to accurately reflect how sick our patients are for adequate reimbursement so we can continue to support the programs we want to develop to provide care for these patients. What this system does is it automatically recognizes whether or not the patient has an HCC condition that was recorded in the prior year and whether or not they still have that condition, and if so, if it was reported in the current year. If it has not been reported, that little checkbox is actually a black dot, and if it has been reported, it converts to a checkbox. So we've taught all of our providers how to look for the black dots and convert them into checkboxes. Let me go back here. We then report on this again in an unblinded normative reporting state, so we can see each individual provider, how they're doing year to date with capturing their HCCs and how they're doing over the last 2 weeks. And again, this taps into that competitive spirit among physicians to really drive results. What is the financial impact of that over the past 2 years? Well, we've seen an HCC score rate in one population, our Humana Gold population, go from 1.04 to 1.22. That's a 17% increase, which translates in that population alone to over a $7 million increase in reimbursement. We've seen increased reimbursements from other areas besides capitation. As Phil mentioned, most of our contracts in primary care have value-based components attached to them. And here's one from Blue Cross. You can see significant improvements in our quality translating into significant improvements in our bonus payments. And these are our current data in this population of how we're doing percentage-wise in each of our Elite 8 metrics.
Additionally, we are now using our registry to implement the new chronic care codes for our Medicare ACO patients. It's generally patients with 2 or more chronic diseases and who qualify for that condition. And so we are using an outsourced vendor at this point called Care Harmony, and we're using our EPIC registries for chronic care to outreach to patients and get them enrolled in the program. Today, we're re-importing the data into our EPIC platform. And I would say, as of today, we are over 1,200 patients enrolled in the program. So we're having really good success in getting patients enrolled in chronic care management. Now, the other thing, we're going to start shifting our focus a little bit in terms of how we're utilizing our health platform, to improve the triple aim, right? Keep coming back to that. And I like this slide in terms of understanding really how medicine has evolved, right? In the 19th century, we didn't have good understanding of pathophysiology, so we treated symptoms. In the 20th century, we really focused on treating diseases, whereas now we're really focusing on maintaining health. And you see all of the things that we're relying now on our technology platform to really enhance our ability to treat our patients. And these P's are just many, many things that you're all working on as well. Incumbent on that is really capturing the data, and we're happy to say that we are now using our platform to expand really our data information set that we gather from each patient. This is a particular screenshot of some of the new questions we're going to be asking in the area of social determinants, where we're really focusing on understanding things like transportation issues, food insecurity, social connections. So we're really now starting to ramp up our whole involvement in social determinants.
And this represents more data in our social history capture. You can see everything from transportation needs and food insecurity, all these issues that we know are significant involving the care of our patients.
And this just gives you the final results as to what this looks like. So as we turn on this functionality, everyone in the system will see this display of the status of social determinants for every patient in the system. And we're going to be turning on this functionality sequentially as we go forward. I think along with this, the other corollary is we were very successful in partnering with a national website called auntbertha.com to provide community resources. And here's an example of how we would link out to community campaigns as we identify issues. So I've been we're just starting down this path, but we believe it's going to help our patients to get the needed services that we identify.
Yes, so in this program here, you basically can look by zip code up to any type of need that a patient might have: food insecurity, housing insecurity, paying utility bills, et cetera. And again, all of this we know now affects patients' outcomes and patients' care. So if we're going to be able to be successful in achieving the 4-point aim here of being able to provide increased quality, reduced costs, a better patient experience, at the same time not breaking the backs of physicians, we realize that IT has to be a critical partner for our population health team, and I think we've had tremendous success in the past and look forward to doing more of this work in the future. We welcome anyone to contact us if they have questions about the work we've done here, and again, really look forward to hearing from you and continuing this great work. Thank you again to the HIMSS organization for the Davies Award, and we enjoyed speaking with you today.
Thank you both for the great presentation. I'd just like to remind folks where to go and find other Davies use case webinars and information on how to apply for Davies Award. That could be found at the Davies website at hims.org/Davies. And if you have any questions, please feel free to give me or Jonathan a call and or email us, and we will be glad to answer them. Thanks again for the great presentation.
Thanks.